Dr. Saurabha. I am an assistant professor in nephrology at JSS Medical College, Mysore. Greetings from Mysore. So it's with great pleasure and pride that I invite you all, the audience and all the esteemed panelists for today's joint session organized by WIN India, the Women in Nephrology India group, and WIN Cardiology and Related Science group on the occasion of World Heart Day being celebrated today. It's a pleasure for that both a dream conference of both nephrologists and cardiologists to be together on this platform today. So we have planned a joint cardio-renal symposium. As we all know, September 29th of every year is celebrated as World Heart Day. And this time's theme is Use Heart for Every Heart. And before we begin the sessions, first of all, I would like to congratulate and appreciate all the cardiologists out there. Thank you for all the wonderful work you do. We really appreciate and thanks a lot, particularly as nephrologists. Majority of our patients have a significant CV disease burden, and we are really thankful to you all a lot. So I'm told WIN Cardiology Association has also had a recent conference, national conference, which was celebrated at Nizam's. It's a beautiful group of vibrant women who are academically equally enthusiastic, as seen by the encouraging participation in this CME. The Women in Nephrology India group was also started as a small idea, but has grown rapidly over the past 1 year. In fact, it has gained such massive momentum over the last 1 year, thanks to our dynamic senior leadership. Now we are co-hosting with other women associations such as Women in Cardiology, and we are really proud about it today. So without much ado, let us go on. Today's two sessions, we have two sessions planned out. So the first session, each session will have a case discussion followed by a topic presentation and a panelist and a discussion which is wedged in between. To take the session forward, I request Dr. Megha Sehgal, my cheerful colleague. She is an assistant professor from AIMS Patna, to take over. Dr. Megha?
Thank you, Dr. Saurabha, for that introduction and for introducing us to this exciting intellectual program for this evening. Now, without further ado, let me give a warm welcome to Dr. Jyotsna ma'am. She is the professor and head of department at cardiology at Nizam's Institute of Medical Sciences, Hyderabad. She is also the editor of Indian Journal of Cardiovascular Diseases in London and the president of WINCARS. I request ma'am to kindly open the meet by giving us a few words of introduction regarding the same. Welcome, ma'am.
Thank you all for this opportunity and then association with you people. I'm really glad to be work along with this nephrologist. Actually, this may be the first association of the WIN India along with the WINCARS. But our concept of the WINCARS itself includes the WIN India in that. In the beginning itself, the 2 decades back when we started in the 2007, we got the idea that cardiology is not a pure cardiology and mostly related to the association with the other diseases. So that's the reason why we started on the related sciences. So every time whenever we do the WCC, that is Women Cardiac Care, every year, we keep a separate sessions for each system wise. So the cardio-renal is one of the predominant meetings what we conduct every time on the WCC. But of course, other than the WCC, yes, I will say this is the first time we are doing with the WIN people. And Dr. Swarnalatha and Dr. Manjusha used to be contact me before for your before starting the organization. Swarnalatha must have been talked so many times with me how to go about it and the registration and everything. And many of you people approached me for how to start a journal for everything. So we are very, very happy that now we are able to come into the communication and do it. Of course, our active members, as you already know, Dr. Sujata, Dr. Anupama, Dr. Sarita, Dr. Cecilia, and so on and so forth. I can add it with the juniors of the Manikrishna and Archana and all those peoples. So I will welcome, have a good feast of interesting cases for the discussion, and I will hand over back to the presenter.
Thank you, ma'am. Thank you for this kind words. I would now welcome Dr. Manjusha ma'am, who is the professor and head of department at nephrology at Gandhi Hospital, Hyderabad, and the secretary to WIN India. Welcome, ma'am. I would kindly request you to start the meet by giving some opening remarks to the same, ma'am.
Yeah, thanks, Megha, thanks, Saurabha, and thanks, Dr. Josna Madam, for that kind introduction. I take this opportunity to introduce to the august cardiologists out here briefly about WIN India. WIN India has taken its inception about 10 to 12 years back, though it was futile and abortive attempts. We have been successful over the last 1 year conducting our academic activities on monthly basis, which includes international events about 4 to 5 in number. And we'd also conducted a very successful conference in the month of August in the very auditorium of Nizam Center of Medical Sciences. So we are about 300 plus nephrologists, women nephrologists across India. And our mission is to make the kidney care reachable to all the stakeholders involved in the kidney services. So this is what is the motto with which we are going across. And I'm also proud to say that we have started this joint initiatives with various professional societies, which are allied societies of nephrology, such as pathology, endocrinology, and dietitian society, etc. And we are here with you today on this auspicious occasion of the World Heart Day with the WINCARS. So we are eagerly waiting for the cardiologists to teach us on certain salient aspects which are in relevance to the nephrology. Of course, we all understand cardio and nephro just go hand in hand. There's a lot of overlap between cardiology and nephrology. So we are eager to learn from all of you. And I welcome everybody who is there out here for this wonderful session. Over to you, Megha.
Thank you, ma'am. Thank you for the introductory remarks. So without much ado, let's proceed to the scientific session. For the first session, I request the moderators, Dr. Sujata ma'am. She is the Director, Cardiology at Indus Hospitals in Visakhapatnam, and joined by Dr. Anupama Vaijay, the Consultant Nephrologist, Nanjappa Hospital, Shivamogga, Karnataka, to kindly take over and introduce the panelists and speaker first session.
Good evening, everybody. Wish you all a happy Heart Day. So I thank the nephrologies, especially WIN India, for giving this opportunity to co-host this meeting. So I welcome my co-chair, Dr. Anupama. And now without much ado, let's go to the case presentation. The case presentation will be by Dr. Archana, the Assistant Professor of Cardiology at NIMS. And the panelists from cardiology side are Dr. Asha Mahilmaran, and she's a Senior Interventional Cardiologist at Apollo Hospitals, Chennai. And Dr. Cecily, she's not at Apollo, but she's at the Madras Government Super Speciality Hospital, and she's also a Senior Interventional Cardiologist. Over to you, Anupama, to introduce the nephrology people.
Thank you, Dr. Sujata. I thank Manjusha for giving me this opportunity to be on this good occasion here. And I will be introducing our panelists from nephrology side, Dr. Manisha Sahai and Dr. Srilata. Dr. Manisha is a professor and head of nephrology, Osmania Medical College, Hyderabad, and she's also the vice president of WIN India. And Dr. Srilata ma'am is a professor and head nephrology at Government Medical College, Alapur. And I am told that Dr. Anuradha Raman, who is a senior consultant nephrologist from Hyderabad, she was also supposed to be on the panel, but for some reason she is probably not being able to join. And anyway, I welcome her also in her absence. I request Dr. Archana to go ahead with the case presentation.
Pratik, next slide you project, the speakers. Yeah. Madam, can you introduce the speakers, madam?
Yeah, Dr. Archana is the Assistant Professor of Cardiology, NIMS. So she'll be presenting the case. And Dr. Sarita Rao is our dynamic Senior Interventional Cardiologist, and she's going to be talking about the new kid on the block, I would say, and a resurgent kid, rather, the renal denervation therapy. So let's go to Archana first.
Good evening, one and all. I'm Dr. Archana, cardiologist from NIMS. Thank you, Josna Madam, first of all for giving this opportunity, and thank you Sujata madam for guiding to this through this presentation. Here I am going to present a case of accelerated hypertension with bilateral renal artery stenosis. We have a patient of 56-year-old female who was diabetic since 3 years, hypertensive since 2 years, not on any medication, presented with history of shortness of breath and orthopnea of sudden onset. She was diagnosed with accelerated hypertension with flash pulmonary edema. She has a BP of 230 by 120 mm of Hg at her during her presentation, and there was no difference in the BP with other limbs. Cardiac examination was normal. She was started on nitroglycerin nitroglycerin infusion and was titrated according to her blood pressure, and she was given Lasix and started on also on amlodipine. After 1 hour, her BP got reduced to 170 by 90, and injection nitroglycerin NTG was titrated to 5 micrograms. Over next 6 hours, her BP was stabilized to 160 by 80 mm of Hg. She was continued with tablet amlodipine of OD and tablet lacilactone and minipress XL VD. And in view of high blood pressure recording and pulmonary edema, patient was evaluated for the causes of secondary hypertension. In history, she complained of no joint pains, no joint stiffness, skin lesions, or constitutional symptoms. There is no any history of suggestive of connective tissue disorder, or there is no history of any drug intake. Her BMI is 24.3 kg per meter square. She is not obese, she is moderately built, and her CBP was normal, ESR normal, ANA was negative. Her renal parameters were like this: serum creatinine is 1.4, blood urea 35, and electrolytes were normal. Her thyroid profile was normal. Complete urine examination is normal, and spot PCR also is in normal range. Her ECG suggestive of LVH with strain pattern, and echo is suggestive of mild concentric LVH with no regional wall motion abnormality, good LV function, and grade 1 diastolic dysfunction with normal valves. Abdominal ultrasound suggestive of normal renal size and no corticomedullary differentiation was seen. She underwent renal artery Doppler, which showed bilateral renal artery stenosis, right side ostial stenosis of 90% and left side proximal stenosis of 80%. Then she was subjected to coronary and renal angiogram. Her coronaries were normal, but bilateral renal artery showed stenosis with right side ostial stenosis of 90 to 95% and left side proximal 90%. So she bilateral renal angioplasty was done with left renal artery was predilated with a 4 into 12 mm balloon, and 6 into 14 mm express vascular stent was deployed, and right renal artery predilated with 2 into 12 mm balloon and 6 into 14 mm express vascular stent was deployed. The patient was followed up post-stenting and her blood pressure and renal artery Doppler was done and compared with that of baseline and also immediate post-procedure 3 months, 6 months and 1 year. Her BP recordings were like this. There is a gradual reduction of blood pressure, both systolic and diastolic over 1 year. And renal artery Doppler showed patent stents through this 1 year, and blood pressure got normalized without requirement of medications after a renal angioplasty after 1 year of follow-up. These are her images of renal angiogram. Right side showing a 95% occlusion, and left side showing 90 to 95% of proximal occlusion, osteoproximal occlusion. This is left renal angioplasty stent. And this is the right renal angioplasty stent. Following the procedure, there were no complications.
Thank you, Archana. You have proven that cardiologists are doers. No, they don't wait. So why did you suspect secondary hypertension? Because your blood pressure regimen was pretty, not in tune with the secondary hypertension or a resistant hypertension and just amlodipine. Why did you suspect secondary hypertension in this lady?
Because she presented with accelerated hypertension with flash pulmonary edema. And also the onset of hypertension is after 55 years of its first onset.
I think Asha, do you agree with Archana? Do you think she has done right in jumping right into the investigations? What is your take on this?
One of the indications for looking for a secondary hypertension is definitely an accelerated hypertension. In that, I would agree that an accelerated hypertension with the flash pulmonary edema, you should definitely look for secondary causes. Whether you wait it out for a longer time or proceed immediately is a matter of decision. It's definitely agreeable that in an accelerated hypertension with flash pulmonary edema, you should look for secondary causes. That is definitely agreed. And considering our patients, the best catch is when they come for the first time with an illness. Once they go away, very difficult to get them back for any investigation. So I would agree that they went ahead and did a renal Doppler. And having done a renal Doppler and found a bilateral renal artery stenosis, the right thing was to proceed and fix it. And she also has evidence of ischemic nephropathy. And our nephrology colleagues will also agree that definitely it's a pointer to presence of renal artery disease probably. And looking for renal artery stenosis was appropriate in this case. And they have started probably amlodipine and minipressxl because they suspected a renal artery stenosis and they did not want to subject this patient to AC inhibitor. And that probably prevented the patient from going in an AKI. In a bilateral renal artery stenosis, if you had started on an AAC or ARB, the patient would have definitely gone in for an AKI. I would definitely want to listen to our nephrology colleagues as well on this.
Do you agree with her workup? You're happy with the workup? You want to do more? I mean, she has done the ultrasound and renal Doppler quite early. Would you do anything more in a patient with secondary hypertension when you're suspecting secondary hypertension rather?
Yes, we would look at other parameters like other endocrine causes. She has looked for thyroid, which is one of the important things. She has looked for potassium, which is normal. So it's not pointing towards a primary aldosteronism. And the other thing is a pheochromocytoma. Though rare, you should consider a pheochromocytoma. But considering that she has atherosclerotic risk factors like diabetes, hypertension, I think it is appropriate that an atherosclerotic renal artery stenosis is high on the cards in this particular patient. And she's also looked at ANA. She's looked for connective tissue disorders. So I think there has been a reasonable baseline workup and pointers towards flash pulmonary edema and basic diabetes and hypertension. The consideration of atherosclerotic renal artery stenosis seems to be appropriate in this case.
Cecily, what do you think? Should we do a renal angioplasty? Now we know that the role of renal angioplasty is diminishing. We have various trials like CORAL, which though have shown that there is improvement in the treatment of resistant hypertension, that the hypertension comes down significantly. But more and more we see that we are not able to get the results of renal angioplasty in terms of clinical outcomes. What do you say?
Yes, ma'am. In this case, a few things I would like to tell is parathormone also should have been done. And while doing whether subclavian screening of the subclavian arteries was done in this patient. And as a routine, considering a history of any oral contraceptive, additional risk, that is, this patient is definitely a case of renal artery stenosis since it has been confirmed by the renal artery angiogram. But before going to that, thorough history is also essential, especially in females. We need to ask for histories like all these things should be also kept in mind, and other hormonal imbalance, urine vinyl malic acid, as rightly said by Asha ma'am. All these things should be kept in mind. But once we are concluding the diagnosis, was a subclavian angiogram also done, whether there was any associations or only renal artery stenosis alone in this patient, it was ruled out. I would like to insist. Then coming on to the treatment, if this patient is having, in spite of all the drugs, putting in the 4 to 5 drugs, despite that the BP is not under control, if she has recurrent pulmonary edema and her renal is also on the deteriorating side, then definitely this will have an edge. Renal artery stenting was definitely an option. And following that, we need to monitor them to have the outcomes, especially an ambulatory blood pressure monitoring will be helpful for such patients, and to periodically assess the renal, creatinine and urea levels, as well as the EGFR.
No. What I'm saying is, in this patient, yes, bilateral renal artery stenosis, there's flash pulmonary edema. She's justified in doing a renal angioplasty. But
Yes,
what do you think? Why is the role of renal angioplasty diminishing? And in the current era, what are the indications for renal angioplasty?
Yes, ma'am. In the current era, these are the things we are telling, ma'am. One is flash pulmonary edema is definitely an indication. A deteriorating renal function is definitely an indication, and it is not responding to drugs. They are consistently there is. But the thing is, these people maintain for some time. Then once again they go back to the blood pressures tend to shoot up. That is why it is being not thoroughly 100% accepted now.
She doesn't have, let's take a fictional case. She doesn't have bilateral. She has unilateral. She has no flash pulmonary edema. Would you do the renal angioplasty in such a situation?
No, ma'am. No, ma'am. No.
You will not. So what are your indications? When would you do a renal angioplasty?
I will do a renal angioplasty. That is what, ma'am. When it is not responding to drugs, in spite of optimal dose, maximum dosage of all the antihypertensive combination given, still the patient continues to have high blood pressures. Her renal condition is worsening, and she is coming recurrently to the hospital with flash pulmonary edema. I think that would be the indications for renal angioplasty, irrespective of whether she has a single artery stenosis or double stenosis. And if the occlusion is very critical, then definitely renal angioplasty has got still a role now.
I think we'll ask our nephrology colleagues what their take is on this situation. Dr. Anupama, can you please take over and what is your
thank you, Dr. Sujata. So I am a little curious, like, what if is in the light of those recent that it's not so recent, but anyway, the trials, Coral and Astral, what Dr. Sujata referred to. In the light of those trials, there has been a bit of hesitation on our side to push the patients towards angioplasty. Probably in the previous days, if there was lesions which were demonstrable lesions, osteal lesions, amenable to angioplasty and stenting, probably we would have asked the cardiologist to go ahead with the stenting. But after the 2 trials, which showed that these interventions are not, or you can say that they're on par with the medical treatment for hypertension, there has been a little bit of backtracking on our side. So I would like to know from Dr. Srilata what her thinking is regarding the patients, the treatment of these kind of patients, how she would advise such patients. Dr. Srilata?
Can I ask just one question? Was the coronary angiogram also done for this patient because diabetes, hypertension, 56-year-old and flash pulmonary edema?
Asha.
Was that
Yes.
also done?
Yes,
Yes,
ma'am.
coronaries were normal.
Coronaries were done.
Coronaries
But,
were normal.
were normal. Okay.
I'm Dr. Srilata. Regarding this patient had a flash pulmonary edema with accelerated hypertension. Is one of the definite indication for revascularization. But otherwise, if the blood pressure is well controlled and there is a huge collateral circulation for the kidney, if that lesion is hemodynamically insignificant, that does not require any revascularization. That is so the role of revascularization should be individualized. We should see whether that lesion is hemodynamically significant in terms of deterioration of GFR with AC inhibitors, hypokalemia, Doppler parameters. All this tells you that this lesion should be corrected by revascularization. Otherwise, if the blood pressure is well controlled, GFR is maintained, patient can be continued well on medical treatment unless it is a solitary functioning kidney with significant obstruction.
There is a question on the chat box. So this is basically a bilateral RAS. So I'm sure TTPA renogram was not done. I'm told. And what do you think, the nephrologists in the panel, about the renal function? What does the renal angioplasty do to the renal function? Supposing the patient has got a deteriorating renal function and a renal artery stenosis, would you recommend renal angioplasty?
Yeah, if the GFR is deteriorating on medical treatment, we will try to revascularize the functioning kidney. Both kidneys are, one kidney is non-functioning, other is functioning, or it is a solitary functioning kidney, and GFR is deteriorating. In spite of blood pressure control, patient may be benefited with revascularization.
That comes with that, I would come to my next question. What are the other tests that you would conduct in such patients to determine which, determine one is determine the significance of that stenosis, and any further tests to be recommended to such patients before we take the treatment decisions? Madam, I think you're the only one on the panel now.
Okay.
Yeah, no, I'm there.
Yeah, Manisha is there.
Manisha.
Yeah, so flight is about to take off, but I'm there still. So actually, I fully agree with Dr. Srilata regarding the previous answer which she has given. Now, my question, what you have asked, whether the anatomically visible stenosis, is it functionally significant? That's the whole idea.
Yeah.
So if the stenosis is less than 80%, and there is no functional significance, meaning that there is no hypertension, there is no systolic bruit, there is no hypokalemia, and there is no deterioration of renal function, we won't treat that as a significant stenosis. The presence of an anatomical stenosis does not equate with a functionally significant stenosis. So functionally significant, as I said, it should manifest. Either it should be more than 80%, accompanied by hypokalemia, deteriorating renal function, or systodiastolic bruit, which indicates this. In addition, Doppler parameters, as Dr. Srilata pointed out. Then, apart from that, you can look at the scintigraphy as well, which also helps to delineate, especially in case of unilateral renal artery stenosis. Then angio, again, you can look at the gradients. So always remember, an anatomical stenosis does not equate a functionally significant stenosis. So that's my take on it.
Interesting. So Asha and Cecily, we always assess the functional significance of a stenosis with our Doppler wire. Dr. Manisha, we have a Doppler wire. So we have an FFR wire and we put it across, we monitor the pressures and then give adenosine and then see if it is functionally significant. Do you think such things, once I did an FFR in the renal artery with dopamine, have you people done that? Since
there are reports of doing RFR or FFR and renal artery stenosis, more like experimental studies, but it's not being routinely done. Personally, I have not done.
It is not routinely done.
Absolutely. So it's as per the guidelines, it's not done routinely, but we are aware of the case reports but it's not done routinely. And many of the
Yeah,
times most of the times we are able to manage the patients well. And I mean, with the parameters which I just now highlighted, we are able to find out if it's significant or not. And one more thing, in addition to what Dr. Srilata said, I mean, we would never try to revascularize a dead kidney. So we also look at the size of the kidney, the size, the books mentioned less than 9 centimeters, or in case sometimes, I mean, sometimes a biopsy is also, if suppose it's available and it shows atrophied kidney, we won't there is uncontrolled hypertension, and there is also a significant renal function in the kidney on the steno side, we would try to revascularize it. And generally a cutoff of 4 milligram per DL creatinine is thought to indicate whether the kidney is functioning or not functioning. But as I said, I mean, size also is a simple tool, and 8 centimeters kidney, you are not achieving anything by doing a revascularization that side.
Also, we do a DTPA captopril renogram to assess the split GFR, so that better functioning kidney will be revascularized at the first time.
But in this patient, we have bilateral renal artery stenosis.
Yeah.
So I think we cannot assess the split renal function as you are pointing out. So, Dr.
I think one of the important points we would like to consider in evaluation of hypertension is extremes of age, sudden deterioration of blood pressure control. So that is very important. Presence of flash pulmonary edema, accelerated pulmonary hypertension, coexistence of peripheral arterial disease. So all this points to probable of secondary causes.
Fall in GFR on starting AC inhibitors or IRB is also a clue for
absolutely
possible.
Absolutely. Absolutely.
And also along with diuretics also, if there is a fall in the, it is not responding along the current guidelines they have given, along with the AC inhibitors, even diuretics also can cause. It is not responding to diuretics resistant hypertension, as well as a fall in the renal function. Once again, an indication to probe for renal artery stenosis, which could be significant.
I had an elderly diabetic and hypertensive female on follow-up for 10-15 years. She had blood pressure well controlled. Suddenly, totally shot up, and even with 5 drugs, I could not get it below 180, 120. Then on evaluation, she had a critical bilateral renal artery stenosis. And after bilateral stenting, again, she's back to just a single drug now.
The literature says that
sudden deterioration.
Up to 30% of diabetics will have atherosclerotic renovascular disease.
And as the age advances,
it will be more.
Increased incidence.
Especially if it is associated with a peripheral vascular disease. Much more incidence of renovascular disease if there is peripheral vascular disease.
I would like to ask my nephrology friends that if there is unilateral hypertension, and I mean unilateral renal artery stenosis, and uncontrolled blood pressure, would you send for a renal angioplasty if there is renal artery stenosis?
If it is a resistant hypertension with assessing the functional significance.
Could you just define what resistant hypertension is?
Requiring 3 antihypertensives, one of which is a diuretic, optimal dose, blood pressure still more than 140/90.
Yeah, and
without any other
patient is adhering to the treatment.
That is also important.
Patient is on 3 drugs, that is diuretic, ACE inhibitor or an ERB, and a long-acting calcium channel blocker. So
without any other demonstrable pathology.
Yes.
Yeah.
Ma'am, in the recent article in March 2022, AHA, they have confirmed that apart from the choral study, which was in 2015, the current recommendation, they say that if it is not getting controlled with all drugs, as you said, if they're taking patient, we are confirming they're taking the proper drugs, they are developing repeated pulmonary edema, better to go ahead with the stenting, ma'am. That is the current consensus also. Despite there are a lot of trials which negate the effects, but still in the current guidelines, they still recommend. ESC is yet to approve that confirmed.
Yeah, but they should be on all the 3 drugs, right? The ACE inhibitor, ARB, or calcium channel blocker plus diuretic.
Plus diuretic, yes, ma'am.
Yes.
Literature is more in favor of an intervention nowadays. Even the real literature. Decision should be individualized.
Dr. Muthu Jayaraman has asked a question. Renal vein renin levels or peripheral vein renin, does it help in deciding management?
It will be helpful to decide which side is to be revascularized. If the hypoxic kidney will produce more of renin, so there is more significant high renin from that renal vein.
Yeah, but they are done only in very special cases.
Very special situation, not a routinely done procedure.
Yes, and non-invasive tests are there. So most of the times Doppler and the captopril renogram, if it were to be
sufficient.
A unilateral renal artery, is fairly good. Go for the angioplasty. That's how it can. No longer done now. Neither the captopril stimulated renin or baseline renin, nor the renal vein renin, they are not done.
There's a question for you, Cecily. How do the outcomes of stenting differ based on the etiology?
Outcomes of stenting, ma'am, if there is extensive atherosclerotic lesions and we are not able to cover up, then surgery will be an option. That at that point of time, surgery is an option. But depending upon the nature of atherosclerosis, ma'am, if it is very aggressive, there is a risk of once again restenosis and other things will be there.
Fibromuscular dysplasia, I think the results of stenting in fibromuscular.
Yes, ma'am. Fibromuscular, yes, ma'am. It can be done in FMD only. It is indicated, ma'am.
That's
do you put stent for FMD?
Not always required. Even a POBA, if it's a good result, you can leave it alone for a fibromuscular.
Alone is sufficient usually.
Yeah.
Okay.
Alone is sufficient.
Takayasu with renal artery stenosis, what do you say, Asha and Cecily?
Takayasu is a more difficult subset, and it does not yield very easily to balloon dilatation. And sometimes stenting may be very difficult, and you may have to compromise only with balloon angioplasty, and high risk of restenosis rates because they have generally an active disease going on as well, inflammatory. So higher chances of restenosis also in these cases.
Yes, I mean, Takayasu arthritis, better to manage them, especially when they're at the active stage, the ESR is very high. There is a rapid progression to suppress them with immunosuppressants, proper with drugs. Stenting should be kept as a very second or third option. Drugs will be the right choice. And once they are in the active
in
stage
remission,
of being declined, then we can. The risk of restenosis is very high now. So it will be kept as a third or fourth.
Anupama, we'll continue the discussion or we'll go on to the talk.
As you say, ma'am. I think we'll just end up with what is the medical management for these kind of cases. If the patient is not suitable for angioplasty or stenting, what is the optimal medical treatment for these kind of patients? Srilekha, ma'am.
The best treatment option will be the tight blood pressure control. The target blood pressure should be around 130/80. And if it is a unilateral renal artery stenosis, the ACE inhibitors or IRB will be the best. If it is bilateral, these are contraindicated.
And statin whenever required.
Okay. For bilateral renal artery stenosis, it is not contraindicated, where we control the blood pressure usually with a calcium channel blocker. Most of the situation, calcium channel blocker is required because blood pressure will be very difficult to control. And if it is along with calcium channel blocker, you can add the next one, depending upon the blood pressure. Then most of them will be benefited with a dose of statin because it is a vascular disease. And the cardiology take up for a prophylactic primary prophylaxis with antiplatelet, you have to discuss. What is it take on by the
Routine,
cardiology people for primary
routine
prophylaxis?
antiplatelet therapy is not recommended.
Not
But if you
recommended.
have evidence of atherosclerosis, then you can give antiplatelet.
Yeah, these are patients usually with a diffuse atherosclerotic
Yes,
Atherosclerotic
yes.
itself.
Atherosclerotic etiology, we will give an antiplatelet, single
Okay,
antiplatelet.
There's very few cases of rarely described congenital in tuberous sclerosis, conditions, neurofibromatosis, which can also be present congenitally, renal artery stenosis. That's a different entity where antiplatelets doesn't come into the room. Whereas,
yeah, that's. But 80% is atherosclerotic.
Yes, ma'am. Yes, ma'am.
I think we had a nice panel discussion where we've discussed the role of renal angioplasty. And now we move on to Dr. Sarita. Dr. Sarita is a dynamic and aggressive interventional cardiologist, senior interventional cardiologist from Apollo Hospitals, Indore. And she will be presenting the role of renal denervation, which, as I said, is a resurgent kid on the block. With the new trials presented, the Simplicity Hypertension 3 and Radiance 2. I think let's listen to her and see what's going on. Sarita, over to you.
Thank you, Dr. Sujata. I'll just share my screen.
Meanwhile, I'll thank my co-chair, Dr. Anupama, Dr. Cecily, Dr. Srilata, Dr. Asha for engaging in an interesting discussion.
Thank you, madam.
Sarita. Dr. Manisha also. She's been from the flight.
Yeah. Thank you. Thank you.
There is some problem. I'm not being able to share.
Sarita, you should change your Mac.
It always happens with Mac. So whenever I'm doing on the other system, it never happens. But the moment you go to a Mac, this happens. Dr. Sujata, give me 2 minutes. Can I?
Yeah. Meanwhile, I'll engage the audience. Don't worry. Take your time. So renal denervation, we know, is, cardiologists and kidney. We should engage in more discussion. And, we are always doers and you guys have to pull us back, So that's happened with renal angioplasty. Hope you guys don't pull us back with renal denervation. And the renin-angiotensin system is an integral part of the whatever is happening. So can you all tell us why we should do a renal denervation? Why the RAS system is so much in?
Ma'am, sorry to interrupt. There are a few questions in the question and answer session and also the chat box. So in between the session after this, maybe if we have time, we can do a question.
By the time Sarita is on, we can complete 1 or 2 questions.
Okay, ma'am. So there was a question on ankle brachial index utility. And it's particularly in diabetics in predicting whenever there is resistant hypertension. So how significant is assessing ankle brachial index in predicting atherosclerotic renal artery stenosis in diabetic patients?
Cecily, want to answer that? You're muted, Cecily.
Oops.
Yes, ma'am. The question is about ankle brachial index.
Yeah.
Yes, ma'am. The question is whether it is related to atherosclerosis, they are asking, ma'am.
What is the significance of assessing ankle brachial index in predicting atherosclerotic renal artery stenosis in diabetic patients with resistant hypertension, ma'am?
Yes, ma'am. Definitely it has a correlation. The peripheral
Definitely there is a role.
Yes, ma'am. There is a correlation. Definitely.
Just
Sorry to interrupt everyone. Pratik, can you just help Dr. Sarita to share her slides, please? Can
Is there tech support who can, get into my system?
Yeah, Pratik, are you here?
Yes, ma'am. I'm
Yes,
here.
Please contact Dr. Sarita Rao.
Remotely?
Yeah,
Yes,
ma'am,
please go ahead.
what you
Yes.
can do is just share the screen rather than sharing your presentation. When you click on share screen, you click on share screen. So what do you say, the first box which comes, you click on that and then go to the PowerPoint.
Not allowing me to share, it's going to system preferences.
Okay, so ma'am, I'll give you my email ID. Can you mail me the presentation? I'll put it on.
Do you have a MacBook? It will only work on a MacBook.
Oh, no, ma'am, I don't have a MacBook.
Okay, give me a second. I'm just logging out of this and logging in with my other MacBook. Okay, give me a second.
Okay, ma'am. Okay.
Okay. So meanwhile, we answer the questions. So Cecily, as Cecily has said, it will only give us a clue, ankle brachial index, but that there is peripheral arterial disease, and possibly there could be renal artery stenosis, but there's no correlation as such. And there's a question, what is the role of filter in bilateral renal artery angioplasty? Cecily or Asha? Yeah, we don't use
filters. Do you use it regularly?
Role of filter in renal angioplasty, bilateral renal angioplasty.
Actually, it is indicated, but normally nowadays we don't use it. Only for carotid artery stenting, we use it. Actually, there is an indication, but it is not being.
Archana, while you're on it, generally we try to avoid pre-dilatation. We generally try to do a direct stenting so that we don't do too much debris dislodgement also. There's also, I prefer to do direct stenting. It depends on the operator, I think.
Okay, ma'am.
Any more questions?
There was a question on use of renal, SGLT2 inhibitors in renal artery stenosis, ma'am.
SGLT2 inhibitors.
That you should answer.
It is given now for everything, ma'am. There is no contraindication.
Yeah.
Current recommendation is we can give it for everything.
Everything. Molecule of the decade.
Molecule of the decade.
So maybe as the SGLT2 inhibitor will add to the control of hypertension. I think it brings down the blood pressure about 2 to 3 millimeters mercury.
That's all.
And
That's all.
maybe meanwhile, CKD, it is so difficult to control the blood pressure in patients with CKD. So do you, Dr. Srilata, you're talking about the target of less than 130. Would you suggest targets of less than 120, considering that it is so difficult? It involves a lot of polypharmacy.
We tried to reduce the blood pressure to at least 130/80 if this is a parenchymal disease and a young adult, otherwise healthy. We try to control the blood pressure with 3 or 4 antihypertensives. Unlike in an elderly man with all sorts of comorbidities, we try to maintain at 130/80, 140/80, like that. And this tight control is much more important in a proteinuric renal disease.
Yeah. So the other question we want to ask our nephrology friends is, so there are people, whenever there is chronic kidney disease, RAS inhibitors are not used. What is your take on RAS inhibitors and chronic kidney disease and hypertension? Would you prescribe, or what is your take?
Yeah, AC inhibitors or IRB are renoprotective anti-proteinuric drugs. So they are definitely beneficial in early stages of renal disease with proteinuria. May not be that beneficial or equal to other antihypertensives in a non-proteinuric renal disease. But definitely, proteinuric renal disease will be benefited with AC inhibitors with respect to reducing proteinuria and delaying the progression of deterioration of GFR.
At what GFR would you contraindicate these
If the
drugs?
patient is on regularly on AC inhibitors, there is no cut of GFR to stop it. But if it is started for the first time in an elderly with multiple comorbidities and vascular disease, you should be careful. It may deteriorate his GFR. And it has to be stopped during intercurrent illnesses with volume depletion, other nephrotoxic drugs. It may push the GFR significantly down. So we stop these drugs, change them to other antihypertensives like calcium channel blockers, tide over the crisis. On follow-up, we start on small dose, increase to maximum tolerated dose.
The other question I would want to ask, because in resistant hypertension, the drug, the most importantly, we are evaluating for primary hyperaldosteronism. So we're looking, and also we are starting spironolactone or eplerenone. So would you, what is happening in patients with chronic kidney disease?
They are all usually with secondary hyperaldosteronism because of some volume changes and other things. Even otherwise, aldosterone blocking is said to be antifibrotic. So wherever possible, if the potassium is allowed, patient will be benefited with a small dose of 25 milligrams of spironolactone along with AC inhibitors, so that it is cardioprotective for you as well as prevent progression of renal disease. But hyperkalemia is a big issue.
But I hardly see any prescriptions having this drug. So that's the reason why I'm asking you.
It's because of the fear of hyperkalemia.
Yeah, we are afraid of hyperkalemia.
We are afraid of hyperkalemia.
If Pateromys is available in the market, we will use it more frequently.
So there was this potassium binder, that Partiomer. There was a big drama regarding that. It's so expensive.
Pateromer is not available in India still. It is an oral potassium binder.
Yeah. So do you think that maybe in patients with chronic kidney disease and hypertension, with uncontrolled hypertension?
Now the new kid on the block is Finrenone.
Yeah.
It is supposed to cause less hyperkalemia. Probably we'll be using that.
They say that less hyperkalemia, less androgenic side effects, etc.
Yes.
Yes. Yeah.
For the diabetic kidney disease, there's a definite indication.
Yes. We are also looking forward to Finrenone. We use a lot of aldosterone antagonists, spironolactone and eplerenone in patients with heart failure, as well as in patients with LV dysfunction, uncontrolled hypertension, even without, we're not doing a lot of workup for hyperaldosteronism. So are you people doing a lot of workup for hyperaldosteronism in patients with resistant hypertension?
Only if we suspect a secondary hypertension. Secondary hypertension, we rule out renal parenchymal first, because 80% of secondary hypertension are renal disease, that too renal parenchymal disease. Once it is ruled out with the urine analysis and GFR estimation, then we look for renovascular disease. That is also ruled out. Then the next possibility is a hyperaldosteronism. Then we look for the adrenal gland, other things.
But because 20% of resistant hypertension, it is noted to have hyperaldosteronism. And we are using, though we are not searching for the hyperaldosteronism, we are using spironolactone or eplerenone in patients with resistant hypertension. Do you think it is the right strategy?
I think it should be confirmed. If it is only an adrenal adenoma, that is corrected by a surgical intervention.
Yeah.
Why should patient be on lifelong antihypertensives?
Okay. So
patient is not affordable for any reason, or in such cases, I think it may be reasonable to put the spironolactone in such cases.
Yeah, that's all.
I think there is a little difficulty, technical glitch still going on with Dr. Sarita Rao. Probably I suggest to move on to the second case presentation.
Yeah, that will be better.
End of the session.
Okay.
Saurabha and Megha, can you just wind up the session and thank the moderators and move on to the subsequent session, please? Over to Saurabha and Megha.
Thank you, ma'am.
Thank you for this session. Now, moderating the second exciting session of the day, I welcome Professor Dr. Shiva Chabra, who is the Professor of Cardiology at Dayanand Medical College and Hospital and a consultant at Unit Hero DMC Heart Institute from Ludhiana, Punjab. Welcome, ma'am. The other chairperson for this session will be Dr. Kiranna Ismail, madam, who is the professor in the Department of Nephrology at Osmania Medical College and General Hospital. I welcome the moderators for this session, and I request the moderators to kindly introduce the panelists and begin the session.
Yeah, thank you, Megha. Thank you. We had an exciting case presentation. We have seen it, and followed by a very exciting discussion as well. Now we move on to the next session, the second session. Here we have series of lectures lined up to discuss the cardiovascular perspective in CKD. And to discuss to this session, I invite the panelists. From nephrologist side, Dr. Vimala ma'am, Senior Consultant Nephrologist, former Professor and HOD at Government Medical College, Thiruvananthapuram, Trivandrum, and Dr. Urmila ma'am, our very dynamic President, WIN India, and Senior Consultant Nephrologist, Amrita Hospitals, Faridabad, and Dr. Sonal Dana ma'am, WIN India EC member, Senior Consultant Nephrologist at Ahmedabad. And from cardiology side, I invite Dr. Neelam Kaur, Senior Consultant Interventional Cardiologist at Amandeep Hospital, Amritsar, and Dr. Mahapakar Mashadi, Interventional Cardiologist, Apollo Heart Institute, Ahmedabad. I request panelists to take over and introduce the speakers. First lecture will be delivered by Dr. Mani Krishna, Assistant Professor of Cardiology from NIMS. And the second lecture will be presented by Dr. Preeti Sharma, Senior Cardiologist, Associate Director, Max Super Specialty Hospital, Dehradun. Over to the presenter, Dr. Mani Krishna.
Yes, ma'am. Very good evening to all. I'm just sharing my screen. And thank you for the opportunity given. I'm Dr. Mani Krishna from Nizam's Institute. I'm going to present a case of calcific CAD in CKD patient. So here is the patient. Our patient is a 56-year-old female. She's a diabetic since 10 years and hypertensive on drugs since 6 years. And she is CKD stage 4, already on maintenance hemodialysis since 4 years. Like she presented with exertional chest pain of 2 months duration, and ECG wise, the ECG in normal sinus rhythm, there is poor RV progression in the anterior leads, that is from V1 to V3. And 2D echo wise, there is no LV dysfunction. She has only concentric LVH, no RWMA, good biventricular function. And her calcium score on HRCT is 1000 Agustin units, suggestive of high risk calcium, high scores. And her dobutamine stress thallium is positive for inducible ischemia in LAD territory. So that we have subjected the patient to the invasive coronary angiography. This is the coronary angiography in epicaudal view, suggesting her left main is normal, and there is some amount of plaque in the distal left main, and there is visible calcium in the proximal and mid LAD. And LCX is, there is no significant disease in the LCX. This is her. This is the angiogram in cranial view, RAO cranial view, showing the visible calcium in the proximal to mid LAD. Next, moving on to the discussion a little bit, we proceeded as the patient is having heavy calcium in angiographically. So we have thought of having the imaging for her. So this is her OCT run, showing more than 180-degree arc of calcium and with a calcium thickness of more around 0.6 mm, suggestive of severe calcium on the OCT wise. So we have wired the LAD with a Cougar XT wire. After that, we went, because of the severe calcium, we have went ahead with the ROTA. So her proximal and mid LAD was, we have taken 4 runs of ROTA ablation with 1.5 mm burr. 4 cycles were taken at 180,000 rotations per minute for a total of 45 seconds. And later the ROTA wire was removed and it was exchanged with run through wire. And this is the video showing post-rota ablation angiogram after rota. After that, the middle part was dilated with 2.25 into 20 mm balloon. After that, the LAD was wide. LAD and diagonal both were wide, and the mid part is dilated with 2.25 and 20 mm balloon. Following that, the mid to distal LAD was stunted with 2.25 into 20 mm stent resolute integrity. This is the video showing distal LAD stenting, middle LAD stenting, sorry. The stent was expanded well. This is the stent bush showing distal middle LAD stent expansion. And the proximal LAD was stented with 2.75 into 28 mm resolute integrity stent. This is the stent expansion following rota in the proximal LAD. Following the proximal stent deployment, there is some residual underexpansion in the proximal LAD. So we have done post dilatation with a 3 into 10 mm balloon in the proximal LAD. This is the final result after stenting from proximal to middle LAD, showing a good expansion in the mid and proximal part following rota ablation. So this is a small discussion part that I've added in the end. So this patient has angiographically visible calcium. For us, angiographically, there is visible tram track appearance in the calcium in the LAD territory, suggestive of severe calcified nodule. In that, if through the imaging, if IVUS or OCT assessment, if the calcium arc is more than 270 degrees, or if the thickness of the calcium is more than 0.5 mm, if the length of the calcium is more than 5 mm, then there is an indication for calcium modification, either with rota ablation or orbital atherectomy. After the stent deployment, we should ensure that complete stent expansion under the full length of the segment should be treated with the that is being treated with atherectomy is covered with the stent or not.
Thanks. So thanks. Yeah, thank you, Dr. Manikrishna. It was indeed a very exciting case and a case of stage 4 CKD, which we actually encounter day in and day out in our practices. And now that you have given us an insight to a patient who is, actually needing revascularization, I think we roll the ball on it. I welcome my co-panelists for the discussion. Dr. Neelam, you are there. We are here discussing WIN India and a WINCARS meeting where we are all women. So the cause of us is same, to study these diseases in detail in women. Do you think that there is some kind of gender difference when we talk of coronary artery disease in a patient of kidney disease, diabetic kidney disease to be more specific?
Well, all of us know that in general population, the incidence of coronary artery disease and cardiovascular risk is very high in males. But taking into consideration the CKD, the prevalence still remains a little bit higher in case of males only. But the incidence of coronary artery disease and other cardiovascular disease and mortality remains is at par, almost at par in women as well. So basically, we need to take care of, risk factors, and we need to look into aggressive evaluation of such patients with chronic kidney disease in women, because these ladies are also at very high risk of developing cardiovascular disease, mortality, and morbidity, and the risk is not same as in general population.
Yeah, very rightly commented. And as per the CAD ref registry, which was there at the CERC trial, you're very rightly commented that actually the incidence, if we look into the incidence, CKD is prevalent equally in both sexes. And if we talk of mortality, which occurs in either of the sexes, the sex has got no bearing actually on the
it's almost
mortality.
the same in,
of course, multi-vessel disease was seen more in women. More women were inflicted. Yeah. So these the red HFCAD registry and the CERC trials have very beautifully shown that. So now that we understand that CAD is equally present and women have got equivalent mortality and no less as compared to men, and we need to look into this counterpart, I would like to ask Dr. Mahapekar, we've been discussing of late so much about zero contrast PCI. We want to save our patients from any level. Ali would be there, giving us the benefits. But of late, there has also been a lot of discussion about ultra low contrast PCI versus zero contrast PCI in a patient of CKD. And we also have so many trials like ROTA, they've studied and they said excellent results in spite of the amount of contrast used, the long-term outcome remains same. So what is your take on zero contrast PCI versus ultra low contrast PCI in a CKD patient, and how would you approach these patients?
CKD patients. First of all, let me apologize for the sound behind me. I'm trying to diminish it, but we have a Garba night going on outside. It's Navratri in Gujarat. So it's a lot of Garba going on outside. So there'll be a lot of noise behind me, and I apologize for that.
We can look at you and we can make out that once the meet is
I'm
over.
straight going. Organizing, the hospital is organizing. So from here, I'm straight going for the RT.
Yeah.
So let's come back to the ultra low contrast and zero contrast PCI. As far as I understand, zero contrast and ultra low contrast PCI, if a person is on hemodialysis, maintenance hemodialysis, and if you're sending him off to hemodialysis, you can use a bit of contrast. It's only the patients who are not on dialysis, my nephrologist colleagues can help me on that. But what we do, our protocol, institutional protocol, and what I understand is, when the patient is not on dialysis, when you're trying to preserve the patient, then the zero contrast and ultra low contrast PCIs, you have to choose between the paraphernalia available to you. If you do have all the imaging modalities with you, then you go for zero contrast PCI. But as we know, most of the centers, we all work in private setup and we don't have all the possible paraphernalia available to us. In that situation, with only IVAS or with only OCT, going with ultra low contrast would also definitely help. In earlier days, we also used to use carbon dioxide and use mainly in peripheral, but we have used that also as a modality. Again, it comes to the expertise, depending on who is doing the case. Ultra low contrast and zero contrast, the main thing to choose between the two is, what is the condition of the patient? Condition of the patient, the amount of calcium, the extent of the disease, all applies to zero contrast and ultra low contrast.
Right. Yeah, very beautifully said. And so what is your usual preferred access in these patients, Dr. Mahapekar, for a zero contrast if you're planning? You like to go via radial or bicameral?
The CKD patients either have a fistula or they are going to make a fistula in them. And if they are waiting for transplant, then the preferred route, if they are waiting for transplant and if they do have a fistula, preferred route is left femoral, otherwise right femoral. You do not want to compromise their arteries. If they are going to have a fistula on the left side, you can still use the right side, but most nephrologists, at least in our setup, are not very happy for us using the right radial. So we prefer the femoral route in these patients.
Yeah, very beautifully said. You know, there's been a review by Dr. Pratap with so many associates, you know, in the Indian Art Journal, and they have studied. But then again, the limitation remains that if we are comparing these two studies, the long-term outcomes are still to be seen. To buy a risk of a zero contrast versus, you know, not even seeing the TIMI flow in your vessels at the end of the procedure is something which really boggles us, but very beautifully explained. Thanks, Dr. Mahapekar. I think Dr. Kiranmay Ismail is having some questions for our nephrology colleagues also. So now that we're talking of PCI, we can't do without a nephrologist's fitness and concerns pre and post.
Thank you, ma'am. Thank you. With regards to the nephrology perspective, all of us know CKD has a profound risk for cardiovascular events, and it mimics an accelerated aging of the cardiovascular system. So with this regard, I would like to ask Dr. Vimala ma'am, is there any difference of CKD in a general population and in a CKD population? Cardiovascular events are different from general population, I mean, compared to CKD, ma'am?
Okay, Dr. Kiranmay, thank you for the opportunity and good evening to all of you. Definitely going through the literature, there is a definite increased risk of CAD in patients with CKD. The morbidity, mortality, and the response to intervention is all quite different in patients with CAD who have also CKD. Earlier, we thought that CKD should be considered as a CAD equivalent. Now the concept has changed because they have known that patients who have prior history of myocardial infarction, the history of cardiac morbidity is much higher when compared to patients with CAD in CKD. Now, why is it that CKD has got more incidence of CAD? Time permitting, there are 2 or 3 points to be highlighted. There is an traditional risk factor we all know, that is dyslipidemia. There is a reverse epidemiology happening here because low cholesterol and low HDL is associated with a high risk of cardiovascular disease. They say malnutrition and hypoalbuminemia predisposes to inflammation, which produces a high reactive CRP, and that predisposes to CAD. The other factors being there is a citrate accumulation, which is resulting from urea. There is an asymmetric dimethyl arginine. All this will predispose to oxidative stress, decreased production of nitric oxide, endothelial injury, and resulting in CAD. So we know that there are definitely patients who are on dialysis have a very high risk of cardiac arrhythmia and myocardial infarction. And the mortality rate is also, however much we take care of them, the mortality is also quite high. Sudden death usually occurs. That is my take on that.
Thank you, ma'am. Thank you very much. Ma'am, Sonal Dalal, ma'am, I have a question for you. The case presentation has been revascularization strategies. They have presented that. But you think any other newer therapies like lipid lowering therapies will help apart from this intervention, ma'am? What is your take on these lowering therapies in CKD?
The question is to me. I could not hear.
Ma'am, this is for Sonal Dalal, ma'am. Doctor.
Yes,
Sonal, ma'am.
Yes, I could not hear. Yeah, thank you. Thank you for the opportunity. Good evening to everyone. As Dr. Vimla said rightly that the patients of CKD are definitely at higher risk for the coronary artery disease and atherosclerosis, not only because of the associated diabetes and hypertension, but they are also having associated risk factors like oxidative stress, inflammation, insulin resistance, and also they have anemia. Along with that, there is a disturbance in the bone mineral metabolism, which also leads to calcifications. So CKD population is definitely at much higher risk. And so statins are to be used in this population, which is required. But there is a difference of using statins in different stages of CKD. When you use statins in CKD stage up to 3, the statins play a very important role and they has to be given, but we have to reduce the dose as compared to the general population as per the GFR. As the CKD stage progresses and when the GFR falls below 30, then the roles of statins reduces. And usually the dyslipidemia in patients of CKD is of different type. Like they have more of a high triglycerides, and LDL is low and HDL is low. So there is a defect in removal of cholesterol from the macrophages because of the low LDL, and there is also nitric oxide production which is reduced. So in the patients who are having CKD on dialysis, they have a U-shaped relationship with the dyslipidemia. Like if they have a very low cholesterol, that also indicates that they are nutritionally very poor. And so if the cholesterol drops, then we have to see to that they are whether they are dialyzed adequately or not. So in early stages of CKD, yes, we should give statins, but in later stages of CKD, the statins does not play much role. The other important thing about CKD and statins is in patients who are being planned for renal transplant, these statins have a significant interaction with the calcineurin inhibitors like cyclosporin and tacrolimus. So we have to adjust the doses of statins and see the interaction is been taken care of. So this is, and fibrates definitely have a good reduction in the lipids, but there is some amount of apprehension amongst the nephrologists about the rise of creatinine. So in early stages of CKD, unless there is a very high triglycerides, the fibrates are to be used cautiously.
Thank you, ma'am. Thank you for the beautiful reply. Ma'am, the next question would be for Vimala ma'am. Vimala ma'am, Srilata ma'am was describing SGLT2 inhibitors as the molecule of the millennium. So what is your take on their effects in CKD, especially with an existing coronary artery disease? How do they help us?
SGLT2 inhibitors, right?
Yes, ma'am.
Okay. There are many trials now available where they have exhibited SGLT2 inhibitors to study the cardiovascular outcome. We started from the EMPACT trial, then the CANVAS trial, then the CLEANSE trial. All of us are aware of these old trials. But now the current trial that is coming up is the DECLARE TIMI trial, where they have studied dapagliflozin in patients with and without diabetes, and they found that though it is useful in glycemic control, it is non-inferior but not superior to other methods of management in reducing cardiac outcome. Now, there is an important trial that has come up now, that is the CHIEF trial, where there is no interaction between the patient and the doctor. The whole thing is based on symptoms. They have used canagliflozin for this study, and they have assessed symptoms, that is based on the Kansas City scoring system. They have assessed the symptoms of the patient, and they have found that canagliflozin 100 milligram definitely reduced the symptoms of cardiac failure. So that is the recent two trials. Now we have the EMPEROR trial and the EMPEROR Preserve trial, where they used empagliflozin in patients with cardiac failure and reduced ejection fraction, and cardiac failure with preserved ejection fraction. And they found the risk of hospitalization due to cardiac failure was much less when the SGLT2 inhibitor was used. So there is definitely a role for SGLT2 inhibitor. And the other studies we have is the VORTIS study, which is using then the ACCORDS. So many other studies have done, but most of them were given up during COVID because they could not complete. Maybe we will have the continuation of these trials, and we will wait for the outcome.
Yeah.
So definitely we can use SGLT2 inhibitor along with diabetes or not diabetes in reducing blood pressure, weight, etc. in patients with cardiac failure. One question before I conclude, I want to ask, lot of papers now with rosuvastatin and kidney disease. What is the opinion of the cardiologist, whether we should continue to use rosuvastatin or we should switch back to atorvastatin? And there is another study, the CANTAS trial, where they are using canakinumab in reducing the pro-inflammatory cytokine. What is your take on these two?
Yes, ma'am.
So yeah, I think it was beautifully discussed. We have a tendency to use rosuvastatin more in our patients with primary prevention because we have got enough data of the basis of Jupiter. Statins do have their role, and we have been using it in patients with acute coronary events and in secondary prevention. But yes, you must be remembering about the Aurora trial, which was so popularly mentioned, especially for the patients on dialysis and diabetic kidney diseases with the kind of what's said as sunset of statins. I think it was somewhere in NEJM, and so the concern for the use of atorvastatin in patients with CKD definitely remains. But yes, if we have to start for primary prevention, and as you rightly said, the patient is somewhere prior to CKD stage 3A, we do have a tendency to use these drugs. Moving on to our, if any one of other my colleagues do not have any comments on this, then I think moving on with our discussion, which is on revascularization, we understand that the data is very controversial when we talk of a CKD patient. There was a recent review in JACC where they studied about these patients, and we all know in STEMI patients, of course, we have to take up these patients for revascularization. But as regards NSTEMI is concerned, there is still mixed data around, for the patients of NSTEMI when we talk of benefits with revascularization, because the long-term results were more or less same. And similarly for stable coronary artery disease with courage, and especially with ischemia CKD, we know that revascularization is always a question in a patient with CKD. I think Jyotsna ma'am wanted to say something. I just heard ma'am is.
Yeah. Just I want to tell you, Shiba, there is questions in the question box as well as in the chat box. Probably you can address them.
Yes. Yeah, surely, ma'am. Surely. Thank you, ma'am. So prior to going to the next question, as I studied from the chat box, I would like to ask Dr. Neelam. We have been discussing about revascularization. So what is your take on imaging modalities in these patients? We know the amount of contrast we have to give in OCT and how important it can be at times. So how do you take IVUS versus OCT when we are planning for revascularizing a calcified lesion in a patient with CKD? Dr. Neelam?
Hello, am I audible?
Yes, yeah.
So we know that in CKD, the calcific lesions and calcification is very high, and these need to be addressed before you deploy a stent, or if stent is required. Because ultimately, if in calcific lesions, if lesion is not addressed properly, it can ultimately lead to stent failure or so. So we have two very good modalities at present, IVUS and OCT, which both of them have some advantages and limitations, in the sense that IVUS can be used as a modality which can tell us about the length and extent of the calcium, but it has low penetration. It doesn't tell us about the depth of that, and that can be addressed by OCT. But at the same time, OCT requires contrast material for continuous flushing. So we have to balance the two. In OCT, if dextran is available, so that can be a good tool to go ahead for patients in calcific lesions in chronic kidney disease. But if dextran is not available, or the operator is more confident with IVUS, so IVUS can be also a good tool to, it can help us in three ways: pre-lesion preparation, during deployment, as well as the post treatment of the vessel. For example, in case of, it can tell us about the morphological assessment of the lesion beforehand, and it can which can help in calcium modification strategies. Like if the calcium is very high, like ARC is more than 270, and the depth is more than 0.5. So this means that these lesions need to be addressed. So calcification, calcium modification strategies, or are used in those, should be used in those cases. It can be atherectomy or IVL, according to the morphological, I mean, depends on the how the calcium is present in the vessel. So I think both modalities can be used, depends on the operator. If the operator is comfortable with IVUS can be used. And if dextran is available in labs where OCT can be, so OCT can give us a better result because it tells us the depth of the calcium also in a better than the IVUS.
Yeah, wonderful. Yeah, very beautifully explained, Dr. Neelam. In fact, I was reading somewhere, maybe, the upcoming times might see saline being used for an OCT,
Yes.
And that is the time which would be really very rewarding for patients of CKD. So beautifully explained. The contrast remains a concern in patients with OCT. And of course, the zero contrast or ultra low contrast does rely on the role of IVUS in CKD. So thanks, Dr. Neelam.
Presentation.
Now that we've talked about the imaging modalities, Dr. Did someone, Dr. Kiran, did you say something?
Yes, ma'am. Do we move to the next presentation as well, ma'am? There is another case presentation, very zero contrast PCI. Do we move on to that presentation?
You want to have that, or I just thought that if you allow, there are just one or two questions, which are left, which I would just like to, in short, address. Dr. Mahapekar, if you could address the differences in the balloon therapies which are there, and if then Dr. Neelam could also brief on IVL versus ROTA, because that's very important. We have got the pre-calc trial and the disrupt trial. The disrupt trial had around 25% of patients with CKD, and the pre-calc trial with CKD. So if Dr. Neelam could address the issues of IVL versus ROTA, and if Dr. Mahapekar could, before we move on, I know we are short of time, preparation balloons that we have for plaque preparation. So after these two questions, we can move on to the next. In short, yes, not taking more time.
Dr. Shiba, if you don't mind, I would be covering this in my lecture. So maybe if we have a discussion after that, that would be really great. Then we can add on to the things. So if you don't, yeah. So maybe we can move the presentation of zero contrast PCI, and then after my presentation, we discuss on the balloon and atherectomy and IVL differences. That will be
okay. Yeah, if that's okay, because if that's okay, we can do. Dr. Sarita also wanted to present, so maybe we can have it after your presentation. Then, if you want to do it first, no problem. Yeah.
Dr. Rupali was supposed to present zero contrast PCI. Is she?
Yes, ma'am. Rupali ma'am is ready also. Yeah. So we'll move on to the next presentation, ma'am. Megha?
Yes, ma'am.
Yeah.
So we move on to the next session of today, which is again a topic presentation, which will be by
Dr. Rupali?
Dr. Rupali, ma'am. May I please request ma'am to
Hi, ma'am. Okay, thank you. So, just a second, because we both run hand in hand. So, is my screen visible?
Yes, ma'am. Please go ahead.
Okay. So, I think most of the points with the earlier person have discussed low contrast induced nephropathy or attempted ways. So as a cardiologist, we can assure them that whatever we are doing is for the benefit of the patient, and we must try these patients to undergo these cases with minimal damage to the kidney. So the basic issue which was there is contrast-induced nephropathy. We all know that for past many years, the nephrologists and cardiologists have been were worried about that these patients of CKD undergoing PCI, they will have damage to the kidney whenever the contrast is given. These definitions have changed by time to time. Earlier, we used to think that in any increase in creatinine of 0.5 or 25% increase within 3 days enabled as contrast-induced nephropathy. But in 2020, kidney group work got a definition that, okay, we need to include urine volume also. So they came with a definition of any increase of 0.3 milligram per deciliter, or there is a plasma creatinine which is more than 1.5 times, or there is urine volume which is less than 0.5 ml per kg per weight per hour, then these patients should be labeled as contrast-induced AKI in these cases, and these patients are the high-risk patients. What is the incidence when we take these patients? If the patient is of low risk category, the incidence of developing contrast-induced AKI is less, it is less than 2%. When these patients are high risk category, that means diabetic, underlying already CIN has been there, these patients have a risk of developing 12 to 50% of AKI in these cases. But if we see dialysis needed, overall population will be less than 1%. What is the potential mechanism for developing CIN? First and foremost, we assume that there is a direct toxicity of these iodinated contrast medias on the nephrons, which lead to your damage of the proximal tubules. Second, we think that about the micro showers of atheroemboli, more common with your femoral axis, that leads to your decrease in the blood flow in the medulla part. Plus and foremost is both the contrast and atheroemboli, when they both combine together, they cause intrarenal vasoconstriction. So there is redistribution of the blood from the medulla towards the cortex and leading to the ischemia and leading to your contrast-induced nephropathy. So because of this, if we see, it's not just us, it's all over the world. These patients, when they have ischemia, they are very rarely they undergo intervention, because we all as a cardiologist also get worried, because we know when these patients will develop CIN, there will be increases of mortality. So this was a very good review article by IS Bangalore. If we see, only 50% of those patients, despite documenting ischemia, they undergo invasive procedures than compared to non-CKD patients when these patients were compared. And what about the long-term effect? Suppose the patient develops CIN also, then these patients have a very high risk for developing adverse cardiac events in form of mortality, your morbidity, you're developing dialysis. So if the patient is upper panel is your patient with CKD developing AKI in 2 years, they will 23% chances of developing severe event, as compared to the CKD who do not develop AKI in these cases, or the patients with the CKD non-cases. So we know this CIN is a biggest challenge. So what are the different strategies to prevent this CIN or CI-AKI? This is basically the flowchart which we all follow, that we have to assess these patients, whether they are high risk category. And depending on these, we have to start the oral hydration and certain medicines. Most proven strategy is using a pre-procedure hydration, not to prehydrate. Start at least 1 hour before the procedure. Give at least 1.5 ml per hour, and depending on the LVDP, we have to stratify these patients whether to give 1.5 ml per hour per fluid, or at 3 ml per or 5 ml per hour, depending on the LVDP. This was proven by in 2013 by the trial of Position. 9-acetylcysteine, sodium bicarbonate, no data, no meta-analysis have shown that these have proven role, but still we are using it because we know we are not causing any harm. Statins, rosuvastatin have been shown to beneficial, but there is no head-to-head trial, because obviously these patients are undergoing PCI. We will not get any group without rosuvastatin in these cases. They will be on statin in these cases. So obviously statins will already be given in these cases. The biggest thing which we can change is the contrast agents, which is in our hand, which we can do. We all know isoosmolar contrast agents should be preferred in these cases because various trials have shown, and the contrast volume which we can is in the cardiologist's hand, which can be held. So what is different definition of low contrast PCI, ultra low contrast? Absolutely, we're having a discussion. So depending on the eGFR, we calculate the contrast volume. A low contrast PCI, whenever we are giving a total contrast volume between a ratio of contrast volume by eGFR between 1 to 3, that is known as low contrast PCI. If we are trying to be more miser, that means if your contrast volume is less than 1, the eGFR ratio, it is an ultra low contrast. And if we are very daring and brave, then without using any contrast, just on imaging and physiological assessment is known as absolute zero contrast PCI. So there are different tips and tricks how to do these cases in our scenarios. For angiography, we always say give a minimal contrast less than of volume of EGFR. So what are the strategies we use in our lab? We try to do a biplane angiography. In our institute, we have that. So any CKD patient or high-risk patient, we take in on biplane angiography. So we need, instead of taking 2 views on single angio, we get 2 orthogonal views. Try to take smaller French catheters, side hole catheters to be avoided. Dilute the dye. We usually do that, we're not maybe 1:4, we still can put a saline in these cases, which also give good radio opacity in our case. And panning should be avoided in these cases so that we can see the whole artery. Then stage these procedures, because doing the both angio and PCI in the same day will increase the contrast load on the patient. So it's always advisable to stage the procedure. Whenever going for calcific PCI in these cases, we have different challenges in the CKD patient. They are calcified, they are diffuse. We need to assess the plaque morphology. We need to use special devices. I think my next speaker will tell about the calcified lesion. I will not discuss about that. So there are different steps which we have to follow in these cases. First and foremost, we have to engage the kite catheter. In view of my another nephrology, I will not go into detail of what are the different steps we do, but these are these flowchart we have to follow. That advancement of guide wire, your use of imaging, the co-registration and deployment of stent should always be done without contrast, and only final angiography should be done with minimal contrast to rule out perforation or slow flow or reflow. For wiring, a metallic solute or clear stent boost enhancement should be done, and IVUS co-registration is important. So what I told about these steps, I will just summarize in my case example. He is a 78-year-old gentleman. He is diabetic. He had an angiovolemi 5 days back. He presented for this LVF. His ECG was showing ST co-wave, and his LV was dilated with ejection fraction of 30%. The serum creatinine was 2.1 with EGFR calculated for 27 ml. So any nephrologist, when you take it, will be a high risk case of CIN, because if you see his Miran score, he has 57% risk of developing CIN despite using an ultra low contrast PCI in these cases. But since patient was in LVF with recent angiovolemi, we have to take this case because again, he will do LVF and this patient will be not able to salvageable. We stabilize the patient. We did his basal angiogram. If we see, this is the angiogram which we found having a left main was okay. LAD, the culprit artery, was having a severe disease and mid part, and the ramus was a big artery, and L6 was free of significant disease. If we see his RCA, RCA was also critical disease in the proximal part, followed by a mid-severe disease. So what we were dealing with was a LAD long disease with ostia of LAD was not very clear. There was significant disease at the mid-critical part. Since the culprit was LAD, we planned to go for LAD in this case. The total angiogram was done at 12 mm dye. So we planned, we will do IVUS guided assessment. We will do the wiring in the wire skeletal model. So just on the frame freeze images, my diagnostic angio, I wired both the LAD and the ramus. The LAD and ramus was wired. This was the pullback of the IVUS, which was done, which showed me that the distal landing zone of the lesion. We showed that there is no significant calcium in this, and LAD ostia was showing a disease of plaque burden of more than 50%. So this was the part which we saw. This was the distal landing zone, which I marked on my angio. This was the mid part, and this was the ostia, which was marked of the LAD part. So this is the LAD ostia, which was having significant disease, MLA of 3.5, my distal landing zone of about 3 mm, and this was the point of confluence and left mid. Despite not giving any dye, I calculated the stent diameter and the stent length, which was coming about 3 into 20, 48 mm, and just a small puff while placing the stent so that I know I am not missing any part. Stent was deployed. And post PCI in IVUS was done to see the stent expansion and to see the LAD ostial coverage. And if we found a distal stent was under expanded, which was done NC, and this was the final shunt of 4 ml dye, 2 ml in the biplane view, which was given to see the LAD stent. RCA was, since it's got critical, we tried to do it in the same setting. We wired both the arteries, wired the artery, Plaque assessment was done by IVUS, no contrast given. Position of the distal stent, position of the proximal stent, but we missed the little ostia part, so I had to put a small stent above there. And post IVUS showed some under expansion, and this was done. So final the stent was good expanded. So if you see the total contrast volume, including this, was only 30 ml. Post 48 hours, his serum creatinine was not raised, was 1.9. He was discharged after 72 hours, and 6 months follow-up, patient is doing fine. So these patients, just for this example, that ultra contrast PCI is feasible in the setting, and these patients should be taken. We had a discussion about OCT, whether these OCT should be done in CKD patient or not. Again, already contrast you have to give for clearance, but many studies have shown normal saline or colloidal solution and dextran. In our institute, we have a series of about 80 patients we have done with hydroxyethyl starch in our cases. Frankly speaking, not taking CKD patients, but the patients above 30 ml of GFR, we have taken it. And we didn't find any patients with having any CIN in our setup. Post PCI, functional assessment becomes also very important. The FFR and should be done in these cases if we are having a doubt in these cases. So in concluding, revascularization CKD patients should be performed, and it should be ischemia driven. PCI can be performed in these cases with ultra low contrast with guidance of imaging and physiology with high procedural success and without complications. So if a patient comes to us, what we do, we calculate his AAGFR. If we found his assessment of high risk score, go for all the things, plan to go for IV hydration according to LVDP, plan to go for isotonic colloidal management, and go for a low osmolar contrast in these cases, and go for ALARA technique of contrast volume, that is ultra low contrast, zero contrast PCI. I have not done, but there are study case reports which have been done with this, and these serum creatinine should be done in these cases after 24 to 72 hours. Thank you.
Thank you, ma'am. Thank you for the lucid presentation. We now move on to the next presentation by Dr. Preeti. Ma'am, the questions will be taken after the presentation. Thank you.
Thank you, Sarita ma'am, for allowing me to present, and thank you organizers for giving me this opportunity. And my topic is calcium modification strategies in PCI and CKD. So as we have already discussed in the discussion that CKD is a major risk factor, and along with the conventional risk factors, we have other non-traditional risk factors like uremia-related cardiovascular risk factors, inflammation, oxidative stress, and abnormal calcium phosphorus metabolism. And this all leads to significantly pronounced and disseminated and fast progressing calcification in vascular system, including the coronary arteries. And especially if we look at the CKD patients, they have more multivessel disease, small diffuse obstructive disease, which is combined with severe calcification. So we know that coronary calcification is the most significant limiting factor in PCI, and any inadequately prepared lesion are a nidus for stent failure. There are numerous tools to modify calcium, and as discussed earlier, intracoronary imaging is critical in guiding modification strategies. So this is the impact of coronary calcium in PCI outcome. You can see the bold blue line with the first generation stent in moderate to severe calcification. Target lesion failure is 8.7% at 12 months. And with the light blue, it is 6.3% with the second generation stent. So this is the impact of calcification, and how it happens. It actually leads to less vessel compliance, and which can actually lead to impaired, or it can prevent the delivery of equipment. It requires special equipments or high pressure inflations, which can actually lead to sometimes procedural complications. If there is a strut or polymer damage when you're pushing too hard, it can cause stent or polymer damage, or if there is suboptimal stent deployment, it can actually, all of this can actually lead to target lesion failure or major adverse event. So what we are trying to achieve, we are trying to achieve in a non-left main an absolute MSA by IVUS more than 5.5 or 4.5 by OCT, or a relative MSA which is more than 90% of the average reference lumen. A word about stent under expansion or asymmetry. So we know the under expansion is the most important thing, and by any means you should try and correct it. And in case of asymmetric, like eccentric calcium or nodular calcium, just don't try to be overzealous, because if you're trying too hard to push this calcium, you can actually end up with complications like perforations. So management, we have different scores of modification. So I find this very simple. This has been already discussed in the previous talk. So if it is a mild calcification, just go with the balloon dilatation. You have prepared the lesion well, do a stent implantation. But if you find that which was looking a mild calcification and your balloon is not expanding well, you can actually go to the lithotripsy and you can assess by imaging your results. If it is a non-crossable or uncrossable lesion, obviously you have tools like rotational atherectomy or orbital atherectomy. If post-rota or orbital atherectomy, you have suboptimal balloon expansion, you can go for lithotripsy. And IVUS OCT scores we were talking about. So if the score is 1 or 2 points, it is you can try using high or very high pressure NC balloons like OPN-NC. If suboptimal result, one can go for lithotripsy. If 3 to 5 points means moderate to high calcification, you can use lithotripsy, but we all have experienced it. If it doesn't cross, you have to go for obviously a rota or orbital atherectomy. So this is the calcium scoring system. By OCT, you are looking at thickness, which is more than 0.5 is given 1 point, arc more than 180 is given 2 points, and length more than 5 is given 1 point. If you are doing by IVUS, it is a circumferential calcium, 360 degree given 1 point. If more than 270 and length of calcium is more than 5 is given 1 point. Vessel diameter, if it is less than 3.5 is given 1 point, and calcific nodule is given 1 point. So this is how you assess your lesion. A word about atherectomy, rota ablation, orbital atherectomy, and intravascular lithotripsy. There are 3 different atherectomy devices to prepare the calcified lesions. And rota ablation, it is more appropriate in concentric, severely stenosed vessels, or diffusely diseased vessels, and especially in patients who have preserved systolic function. And I will present, so this is the case, 79-year-old male, and he was hypertensive CKD patient with a creatinine of 2.5, had recurrent rest angina for 2 months, normal LV function. CAG done at other center actually shows you that there is some distal left main disease along with a critical LED disease. So this kind of calcium, when you're trying to do you wire it and then change it with rota wire, because you are actually not able to pass. So if we are talking of non-crossable lesion, it is a 2 millimeter balloon. If you are not able to cross a 2 millimeter balloon, try doing these atherectomy devices. So 1.25 bar followed by a 1.5 bar rotational atherectomy done. And the lesion was, we thought that we have done a good job, but once you see the IVUS after rota ablation, you can see that there is still an arc of calcium and the further preparation is required. So what do you do in this vessel, which is somewhere 2.75, you are not happy with using a 1.75 bar. So then you can go for a cutting balloon. So this is a Wolverine balloon, and which has done a good job. You can see the good expansion followed by a stent implantation. And this is the result. And this is the post IVUS. Distal definitely needed some more work with a 5.15 millimeter square lumen, and proximally we could achieve a good area with a good expansion. So how rotational atherectomy is different from orbital atherectomy? Orbital atherectomy is bidirectional. Rotational atherectomy is only front cutting. We have different burr sizes in rota. In orbital, you have 1.25 crown, which fits all. So there is no need to change your guide. As we have to do in a rotational atherectomy, we have to upsize our guide when we are upsizing the burr, and there is less chance of having a temporary pacemaker with orbital atherectomy. And a word about balloon-based plaque modification. So this is a simple algorithm. We have discussed about the severe calcification, and a word that in tortuous arteries and moderate to severe calcification, just do cautious rota and try and avoid orbital atherectomy. And if you are not having moderate to severe calcification, you can go for a cutting balloon or a high pressure balloon, and lithotripsy as we discussed. So the questions are that when do you want to use cutting, as an upfront or after atherectomy, and how? And the most problem with lithotripsy is, will it pass? How will you place emitters? And if it is difficult to cross, and important is the cost. So this OPN-NC, this is a twin layered balloon, and we use it in lesions where there is, ideally it should be used in calcium thickness, which is 0.5 to 7 millimeter, or after a stent or balloon if you have under expansion. With OPN, you have to be careful, just undersize your OPN balloon. Just don't go for 1:1. Otherwise, you can end up with complications. And this is a cutting balloon, Wolverine, and it actually creates microsurgical incision in the vessel wall. And when it can be helpful, we know with the studies that best cutoff to predict calcium fracture with angioplasty with cutting balloons when there is a calcium angle which is less than 198 and thickness which is less than 0.5 millimeters. So these are the patients in whom you should try and use cutting balloons. So this is an example when you are actually, this is pre-atherectomy, post-rotational atherectomy, you have used front cutting mechanism of rotational atherectomy. And now with the cutting balloon, you have actually created focal stress point and you have fractured the calcium, and then it leads to the vessel compliance. And the lower panel is post non-compliant balloon, and you can see that the vessel has did well. So this is the combination of the two you can use for better results. So, algorithm for cutting balloon, if after your atherectomy, rotational or orbital, you have a suboptimal or minimal crack formation and there is a moderate residual calcium, then you can go for cutting balloons. And the word about IVL, so we know with the Disrupt CAD trial that they could achieve 92.4% success in severe calcified lesions. And if we go by the algorithm, so you have a patient who is having a moderate to severe calcification, but there are certain issues like patient is having low EF, you have safety issues. If it is an angulated osteal lesion, if it is a tortuous artery, you can actually use shockwave balloon and IVL, and this can actually bail you out in these kind of difficult scenario. And you can use post-atherectomy, if you have thick calcium after doing atherectomy, then IVL balloon can help you out. So issues, we know this has virtually no learning curve, and this is useful in thick calcium, and you can use it in tortuous arteries, and both it acts both on deep and superficial calcium, maybe safer and faster in low EF patients. But the important thing is cost. So this is one example of IVL. This was a 79-year-old female, and this was a tortuous RCA with ISR. I was skeptical in doing rota, and there was a proximal nodule, which after 2 millimeter, we could not pass a cutting balloon. So by inching method, then we could cross the shockwave balloon, and this is the result. So this is pre and post IVUS, we could achieve good areas. So the key learning, you should have a stepwise approach when treating these lesions with high calcium content. And the goal is to have a fully expanded stent. Imaging is mandatory to guide which therapy would work best, and balloon-based therapy could be used for crossable lesions. Ablation-based therapy could be used for both crossable and non-crossable lesions. And actually, as we have seen in the examples, that both modalities are complementary. And we know that IVL is a highly versatile but expensive, and it can actually treat thick calcium, and it can help you out in stent under expansions because of calcification. And calcified ISR, this is the best tool which can help you out. And it may be preferred in patients in whom there is absolute or relative contraindications to atherectomy. And despite all, nodular calcium can actually trouble you, and these are difficult to modify. Thank you.
Thank you, ma'am. Thank you for the excellent presentation. Ma'am, we move on to the next presentation by Dr. Karishma, ma'am. Since we are running short of the time, we have decided to go for the presentation and take the discussion later.
Am I audible?
Yes, ma'am.
Visible and audible, ma'am. Please go ahead.
Is it on slideshow now? Can you see my slides?
Ma'am, we can see your slides, but it is not on slideshow.
It's not on slideshow? Okay, because on my screen, it's on slideshow.
Can you just escape and
share it again?
Yeah, please.
I'll just stop share and share it once more. Is it now on slideshow?
Yes, ma'am. Now it is on slideshow.
So thank you so much. Good evening, ladies and gentlemen. I'm so sorry for the technical glitch. A very happy World Heart Day to all of you. And thank you to WIN for inviting us for this session. So I'm going to be speaking about renal denervation therapy, the new frontier. Is it ready for prime time? More than 1/3 of the adults we know they suffer from hypertension. And in 2010, it was the leading cause of death and disability adjusted life years worldwide. Hypertension is associated with an increased risk of coronary heart disease, stroke, heart failure, and peripheral arterial disease. And we know that relative risk reduction for cardiovascular events have been shown to be proportionate to the magnitude of the blood pressure reduction achieved throughout treatment. However, many patients' blood pressure still remains uncontrolled despite numerous safe and effective pharmacological options which we have. Also, we do know that it could be because of physician inertia, patient non-compliance with the medical therapy, or a truly resistant hypertension. Previous evidence have also suggested that various neurogenic mechanisms contribute significantly to essential hypertension, most notably an increased activity of the renal sympathetic, efferent, and efferent nerves found within the wall of the renal artery. Ablation of the renal sympathetic nerves has therefore been proposed as a potential treatment for hypertension. A widespread enthusiasm for renal denervation therapy, it was poised as a breakthrough therapy for uncontrolled hypertension, was followed by an abrupt disillusionment after the lack of a demonstrable efficacy compared with antihypertensive therapy alone in the trial. However, there has been revision of the trial design, and there have conducted relative to confounding variables of procedural technique, medication variability, and selection of both patients and endpoints has substantially improved from contemporary studies. So now, with renewed interest and cautious perseverance, recent early phase randomized sham control trials have now demonstrated significant blood pressure reductions following RDN in hypertensive patients, both in the presence and in the absence of antihypertensive drug therapy. So as a pivotal study, the randomized sham control spiral hypertension AFMED was statistically powered to evaluate the efficacy of catheter-based RDN in the absence of antihypertensive therapy, an approach which was similar with the evaluation of antihypertensive medications per se. We have recently done RDN in a no-option patient who was having recurrent transient ischemic attacks. He also had a history of CVA in the past. He was on 8 medications and his blood pressure was still 180 by 110. I'm here today to discuss the procedural aspects of RDN and how we trudge from here in the light of the current success of the therapy. So, just a minute. So this was the spiral hypertension off medication trial, and they compared renal denervation with a sham procedure, and the objective was to assess the efficacy of renal denervation in the absence of antihypertensive medication. And they looked at the baseline adjusted change in 24-hour systolic BP and also some secondary outcomes, and they found that there was no major device or procedural related safety events that occurred up to 3 months. And it showed the superiority of a catheter-based renal denervation compared with a sham procedure to safely lower blood pressure in the absence of antihypertensive medications alone. There was also another study, the spiral hypertension on-med trial, which tested the safety and effectiveness of RDN in patients who were taking up 3 antihypertensive agents. The first 80 patient data was presented this year, and it concluded that there was a sustained BP reduction by 5.9 in ambulatory diastolic blood pressure, 11 in the morning systolic, and 11.8 in the nighttime systolic blood pressure. This blood pressure reduction was sustained over 3 years, and there was no device-related complication. The results of both studies will be included in an application to the FDA for the approval of the spiral catheter in this population. Currently, we do not have any approved RDN devices. Now, what was the problem in the initial studies? So the procedure was actually changed to reflect renal nerve anatomy. The renal nerves have a positional bias on the radial distance from the arterial lumen, and the distal nerves are actually closer. So the renal nerves originate from the aorta and they arborize towards the kidney. The nerve fibers do not completely converge on the renal artery until beyond the main bifurcation. The accessory arteries, when present, have similar anatomical innervation pattern that mimics the main renal arteries, and so
The initial procedure in which we only ablated the main artery, it was changed to ablate as distally as possible where the renal nerves congregate closer to the artery. Ablations are only done outside the angiographic shadow of the kidney. This is the latest Simplicity spiral catheter with which we are having success. It's a multi-electrode catheter with quadrantic vessel contact. For simultaneous ablation in up to 4 electrodes, you can do a 60-second simultaneous energy delivery. The vessel diameter which we do it on is 3 to 8 millimeter, and it has a very flexible catheter which allows branch treatment, and it's compatible with the 6 French guiding catheter. This is the surgical precedent of this procedure, a thoracolumbar sympathectomy, wherein the idea came to do this procedure. So this is a 56-year-old male who presented to us with recurrent paroxysmal episodes of tingling numbness in the right half of his body subsiding spontaneously in about an hour's time. He was referred to us for control of blood pressure. Now, he had a history of CVA with a frontoparietal lacunar infarct about 2 years ago. His blood pressure on multiple antihypertensive was still 180 by 110. Biochemical physical exams were normal. ECG echo suggestive of left ventricle hypertrophy. Normal renal Doppler, ultrasound was okay. Metanephrines are normal. Diagnosed as a resistant hypertension with recurrent TIAs. We escalated his current medication therapy with periodical follow-up and checking for compliance, which was adequate. Gradually, his number of pills went up to 6 with 2 fixed dose combination. So actually, in total, he was on 8 antihypertensive medication on maximal dosage, and still his blood pressure was uncontrolled. So this was what his prescription looked like. He did not tolerate clonidine and amoxicillin, and so we finally gave this patient the option of RDN on compassionate grounds to avert an impending full-blown CVA. I'm sorry because I shifted from a MacBook to a Windows, the videos may not run. So this is basically how you take in the catheter. You take in a micro catheter and then you exchange it. First you take a floppy wire, then take a micro catheter, exchange it to a Grand Slam wire, and then you take in the Simplicity spiral catheter over it. You can see the 4 electrodes over there. This is the Simplicity spiral catheter. It's uniquely designed because it automatically positions electrodes to generate 360 degrees of ablation. The energy is delivered to the renal nerves through the arterial wall. It is a consistent, repeatable 4-quadrant ablation pattern, 6 French guide and a 0.014 rapid exchange delivery, 60-second delivery of energy, and the temperature and impedance feedback is there to control energy delivery. So if you go too high, it will automatically shut off the system. This is how we took it. You have to systematically take it into each and every branch of the renal artery, consistently ablate all the points. It also has a system in which you can shut off any electrode. So if you've already delivered energy to one part and your electrode is overlapping in that area, you can shut off the electrode in that area. Systematically, both sides, the renal arteries have to be ablated. And also if there is any accessory renal artery, you would have to still do that too. All this were ignored in the original Simplicity trials. They only ablated the main portion. And they didn't work on the distal branches. They also did not work on the accessory renal arteries. Also, they were working with the Simplicity Flex, which only had 2 points, 2 electrodes, and didn't really work very well. So let's look at the evidence this far. So with advance in clinical research with pivotal trial and registry, further data will help us to understand the ideal renal denervation patient profile. And so we've had the Simplicity trials. Then there was a clinical trial redesign when they designed the new catheter and found out what was the problem with the initial catheter. And then we had the spiral hypertension off med and on med, which we've been talking about. And then finally, there is the US patient preference study. Now, there's also been another approach to it other than the Simplicity spiral catheter. There's an endovascular ultrasound renal denervation, which has been shown to reduce the blood pressure in 2 sham-controlled randomized trials, the Radiance Hypertension Solo, mild moderate hypertension off medication design, and the Radiance Hypertension Trio, that's hypertension resistant to single pill combination therapy. The Radiance 2 is a larger pivotal device, investigational device exemption trial designed to confirm the effectiveness and safety of ultrasound RDN among patients with uncontrolled and mild to moderate hypertension. This is the RADIANCE 2 trial design. You can look the age group, which was in 18 to 75, uncontrolled hypertension, history of medication treatment on 0 to 2 antihypertensive meds, and the daytime blood pressure between 135 to 170 and a diastolic between 85 to 105, no prior cerebrovascular events, and an eligible renal anatomy. So this is how they went about the trial. And in the RADIANCE 2, they were able to demonstrate a significant reduction in the daytime ambulatory systolic blood pressure at 2 months. This is the largest individually powered randomized trial to demonstrate superiority of endovascular ultrasound RDN in lowering blood pressure compared with the sham procedure. The trial met both the primary and secondary efficacy BP lowering endpoints at 2 months, showing statistically and clinically significant reductions in daytime ambulatory systolic blood pressure. No major adverse events were there. So that confirmed that ultrasound RDN did lower the blood pressure across the spectrum of hypertension. So these were all these sham control trials. The Simplicity 1 and 2 were not sham control. And again, if you look at the meta-analysis of renal denervation versus placebo, you would look at the significant p-value in all of these patients. There's also a lot of other emerging indications for which renal denervation can be used, and they're looking at using it in ventricular arrhythmias, atrial fibrillation, cardiomyopathy, gestational hypertension, also in pulmonary hypertension, and for the endocrine people in type 2 diabetes, and for the neurologist in stroke. So there are a lot of preferred patients for renal denervations, and the Taiwan Society of Cardiology, they have a consensus on RDN. They said that it has to be a resistant hypertension, that there has to be evidence of hypertension-mediated organ damage. It could be for people who are non-adherent, that is patient preference, and adherence has to be explored on a very regular basis and look at inscrutable causes such as inconvenience, forgetfulness, etc. Or either the patient is intolerant because of adverse effects of the BP-lowering drugs, and also still uncontrolled BP with irreversible causes, for example, renal parenchymal disease. So it has been suggested that RDN can be offered to patients as a choice, in particular those who are poor compliant or do not like taking drugs. But in our opinion, RDN could become an option for patients with uncontrolled hypertension only if the data from well-controlled studies shows that RDN works as well as drugs, that RDN can reduce or eliminate drug therapy, or that RDN can cure hypertension. But unfortunately, at the present time, we do not have any of that. So there is no study to date that shows that RDN can replace or even reduce drugs, and there is no data to exist to show that RDN can cure hypertension and potentially eliminate the need for drug therapy. Certainly, we need data using the new methods and techniques and new devices to prove that RDN can cure hypertension in some patients, especially the borderline ones, to reduce the need of antihypertensive medication and the number of medications. Also, we need to collect data in patients with isolated systolic hypertension and to more carefully define characteristics of patients who are more likely to respond to the RDN. Until then, we are glad that RDN is back on track with the last 2 trials being on the right path, and good research will continue. And we need to encourage patient participation in ongoing and future well-designed RDN studies. Still a lot of questions which remain unanswered. How do I identify a patient who's likely to respond? Who's the person who should do these procedures, the radiologist or the cardiologist? What is the energy source? You would like to use radiofrequency or an ultrasound? In the light of recent RADIANCE trial, which used endovascular ultrasound RDN, is the blood pressure lowering effect durable? Will it translate into improved clinical outcomes? Only time will tell us. What are the long-term safety issues? It's still unclear. With that, ladies and gentlemen, thank you so much. I will just stop sharing. This was actually the only the second case of renal denervation therapy, which was done in India, because the catheter was available only on compassionate ground. It has to be imported in from Singapore, and the patient has to pay up front, and there's a 6-month waiting period. Dr. Sujata.
Thank you for the.
So sorry I kept you waiting.
Yeah, so I would add one more point to Sarita's thing. We have no way of knowing whether this we have ablated or not. Supposing we've done an angioplasty, we can see a lumen gain. But what is the marker that you have done a good RDN? That's one more thing.
That's another thing which we don't know, but what they have done in trials is that they've looked at the norepinephrine levels. So they've seen that if you look at the baseline and you see a significant drop in the norepinephrine levels, then possibility you have done a good ablation. But till then, there are no hard endpoints. There's no way of knowing whether the patient is going to respond. There's no way of knowing whether you've done a complete denervation, except that when you're doing the procedure, make sure that you go the entire way, repeatedly ablate every single branch artery that you see, and all the points, right up to the point where it joins the aorta, till the margin of the kidney.
Yeah. So yes, as you have said, the Radiance 2 has created a lot of furor. And there is also a publication which I will talk about, that is the Simplicity 3 long-term results, and which was published in Lancet. But that trial has a lot of criticisms. As you have said, the Simplicity catheter is not, the first generation had not ablated properly. But you know, they unmasked the people, and then they compared with the sham control, and they found that significant, you know, the blood pressure reductions were more than about 20 millimeters. I mean, which are difficult to believe. So the sham control is one good thing about these trials. And we have to wait for more data, but we can say that we have one more tool to our armamentarium of drugs and lifestyle. So what do our nephrology colleagues have to say about this? They're spellbound, Sarita, after you spoke.
No, so I would just like to, you know, say that, Dr. Sujata, for now, it's still only for our refractory hypertension patients.
Yeah.
We do not give this therapy to anybody unless we've tried all our drug armamentarium, because even after we do an RDN, they're still going to need drug therapy.
Yeah.
But yes, it's going to help them control it better.
Yes.
And possibly we are going to get a lot of responders, but we are still going to get at least 30% of non-responders.
Yes.
So in the practical aspect, it becomes very difficult to explain to the patient also that I'm going to try this therapy on you, and it may or it may not work. You have to tell them upfront.
Yeah.
But the fact remains that a lot of people who are no option patients, they come to you, they're having recurrent events and they have nothing on the block. Then RDN becomes a good tool because they anyways have no other option. So for no option patients, resistant hypertension, total contraindication to drug, total intolerance to drug, or you can say the people who can't take it for some reason or the other.
Yes.
Totally irreversible hypertension. For them, it's some kind of a boon. And also they've looked at, you know, a 3-year data. The question about RDN was always whether when you do an ablation, is there going to be a reinnervation which occurs? Because when they transplanted kidneys, they found that reinnervation occurred. So they said that, you know, you denervate these nerves and they're going to reinnervate. But at the end of 3 years, they have follow-up data now at 3 years, and these patients are still going strong. There's no evidence of, you know, coming back. So that's one good thing. We're not seeing reinnervation. Also, they've said that if it reinnervates and your blood pressure shoots up, you can also think about doing a second RDN, because they haven't had any adverse effects with renal denervation.
Safety is proven beyond doubt, as Dr. Sarita has said. I would like to hear from our nephrology friends.
Ma'am, sorry, I would like to disturb you. Actually, we are running short of time, ma'am. We are past 2 hours. Thank you for the excellent presentations and discussion. We are very, very happy that the time has flown actually, but then we may have to wind up the session. The concluding remarks would be given by Dr. Sonnalata. Megha?
Yes, ma'am had some other program. So I will give the concluding remarks. Alas, as all good things.
Megha, I'm here. Again,
Yes,
it's my opportunity to give the concluding remarks. I think it's an excellent session. The first initiative that we had taken across the 2 societies, professional societies, I can say that it is extremely successful on the occasion of the World Heart Day. We have learned quite a lot. I'm sure my nephrology colleagues also will agree to the same. And the talks are tremendous, and the planning by Dr. Jyotsna has been excellent. So, I mean, very informative, and I'm sure we will be able to continue such interactive sessions provided there are, I understand there are a lot of overlapping topics between both the departments. So let us try to continue this and sustain this initiative in the forthcoming time. So thank you everyone. The case discussions that have been selected are extremely informative. And the last session, Dr. Sarita, though we had technical glitch, you could fly off with a lot of information. Of course, it was extremely interesting, but in view of shortage of time, we could not take much of questions on that aspect. And of course, the other three speakers as well. So it has been a lovely session over the last 2 hours. Thank you, everyone. Thank the moderators, Dr. Sujata, Dr. Anupama, Dr. Kiranmai, and Dr. Chabra, and all the panelists who have contributed to the questions and answers. It's been a great session all the while. And I thank everyone, the delegates who have joined online with us, and also the technical team. Thank you, everyone. Good night.
Thank you. Thank you.
And
Thank you.
many more interactions.
Thank you so much.
Thank you, ma'am. So much. Thank you.
Thank you, everybody.
Thank you.